that's a 12-minute, 5-minute break. So, my memory from last year was not that the break was quite as upbeat as this break was last year, if you remember. Maybe it's the M&Ms. Yeah. Anyway, so we're going to move into another phase here. We're going to have 3 different topics, and at the end, Senator Hann will announce his plan for the next meeting. And so if Ms. Bartolek could come down, we're going to talk about corporate foster care. If you recall, this bill is attempting to solve a few problems that we're lingering over. One that we did not adopt yet tonight has to do with the waiver and the 1.67 contingent, the percent contingent rate cut that we are trying mightily to avoid, either by getting the waiver or by getting rid of the money, the short term, and that's one issue. Another issue was this corporate foster thing with immediate closure, which has generated lots of discussions, and a few other smaller problems that the PCA thing, which maybe we'll take up, which has been a problem for some people. So, Ms. Bartolek, we did not rehearse our speech here tonight, and Ms. Hamilton, I would talk to you a lot lately. We met with the commissioner this morning, and did she leave already? It's nice she came. Senator Hann met with her yesterday, I believe. The governor has a proposal to simply delay, any bed closings and then push them off to the future under some plan. With the help of many people, there's been work gone on, and the House version has been all over the map. It's not my intention to go home with $4 million, 4.1 in reductions, and a lot of that was I won't even burden you with where that was, but I just want to tell you my intention now from the side of the House, and then Senator Hann can jump in how he likes. It seems like the most prudent way to go on this is to delay closing any beds this year. That's my discussion as of today, which should make people happy. But I don't want you to be too excited about never doing this, because I think the future is there's either too many or they're in the wrong places, or they're serving some people who don't belong there anymore. And I think with the advent of the 25% option in other sites that are larger, that gives some place to put folks, and I think in a more optimal way. And one of Rahm Emanuel's few quotes I appreciated was, "You don't want to waste a good crisis." And I think that what this has made us do on the healthcare side the last year was to do a lot of things. And lots of people's heads were swimming about all the healthcare side, which this bill, and I think either side, has very little of. The continuing care side engaged and foresaw some things, and out of that came this closure language, which has promoted some really good dialogue, I think healthy debate about how many do we need and where should people be living and all that. And so, especially Ms. Hamilton, thank you for 19 drafts. But I wanted to just discuss philosophically where I'm at, and my role here, I think, is mostly philosophical. I don't work in your area. I work in my professional place. I could give you lots of advice about that, but there's nothing related. But I think that we have to be aware of where the world is going, and it's not in building more 4-unit buildings. It's in more independent living, which everybody seems to want, and this crisis has given us the chance to get there. And so my desire is that all the good ideas you've thought of trying to find money, if we push the start button in 12 and 13, with all the planning that will be going forward in 2013, that automatically that the next step would be to right size, voluntarily close, move people in the right direction, and maybe not require mandatory closures. That's where I'm at today in my philosophy, which I think is healthy, and I think it's a comforting message to some of the providers that have been very worried about $4 million, for instance, which I always disavowed. But so if you can tell me where that takes us, and we'll have to, I don't think there's a fiscal note, but there's an amendment here. I don't know if that's what you're going to talk about. But so with that preamble, maybe Ms. Bartolek and Ms. Hamilton, could you comment? And then we'll get some other people to discuss where we're at. By the time the conference wraps up, we need to have this resolved. But I think there's a lot of groundwork there. And so it's my desire, just to reiterate, the conference last time, the agreement created a crisis that we didn't even know all about. But I want this conference work to resolve it and create future good work without doing any more legislation. So it can just continue on with the department doing work. So that's what I desire, and I think it seems to reflect about 50 discussions I've had with people in the hallways, if I could, that's what I think I've heard. So, Ms. Bartolik, do you want to respond to that, please?
Yes, Mr. Chair, my name is Alex Bartolik. I'm with the Department of Human Services. And as Mr. Chair said, the language did pass in the 2011 special session, which required the reduction in capacity of corporate foster care when someone who was living there chose to move into a more independent setting that qualified as a community living setting. And this proposal that's in the amendment that you have before us buys back last year's reduction in favor of using a need determination process as part of an overall gaps analysis to be able to better understand the needs of people, what's available in their communities, what options they would prefer, and be able to identify where there might be the ability to reduce capacity in corporate foster care across the state. The proposal includes a delay of any reductions in the capacity until beginning July 1st, 2013. There's a requirement to complete a needs determination process during fiscal year 13 that can help us identify where there may be excess capacity in corporate foster care sites across the state, using information from assessments that are done on individuals, from lead agencies, and also from information gathered from providers and communities. The administrative activities in this proposal to complete the needs determination are funded through a shift of local planning grants that were associated with the capacity reduction effort that passed last year. So there's $100,000 for the administration of the need determination process and $400,000 for local planning grants, and then $250,000 a year to continue planning at a local level to help providers and counties be able to plan for alternative services. The language includes a process for the planned closures of corporate foster care and provides the ability to have an enhanced rate for those providers for up to 6 months during the transition. Now, this is the only method that will be used for capacity reductions until December 31st of 2013. There is the authority in the language for the Commissioner to remove unused beds that are no longer licensed, but they may be in the system with plans to do something else with them, and also to delicense currently licensed but empty beds that are in the system. Now, the combination of these authorities, as well as information from the need determination process, will be used to determine where any remaining capacity that is not met through planned closures will be taken in order to achieve the savings that are required by the 2011 and 2012 sessions. There is an exception in the language for any homes that are associated with a mental health provider or that has an optional certification to support people with mental illness that's going to be developed by the department. Those homes will be excluded. It also exempts beds that are used for emergency crisis purposes, for individuals with developmental disabilities or a mental illness. And it expands the reductions that were included last session for CADI and brain injury waivers to also include now reductions in the DD waiver. Article 4 is the area that the gaps analysis is located in. However, the remainder of the amendment is based on Article 7. And because of the contingency nature, the department would need to implement current law until the contingency funding is received.
All right. And so it's actually we have not discussed this, but I would think this should not be a contingency item. I think this should be a cash item. And we'll have to discuss that. But I think when it dawned on me, contingency meant not who knows when it's coming, that this is one of the things that probably needs to be a more certain item. And that's not been agreed. I'm just expressing my opinion right now. So, Ms. Bartolek, this is the latest version.
Yes.
And so maybe if people, and so when people testify, they can address this version and not anything else, unless the Senate wants to have them comment on something, and we can ask that later. And so, do you have a fiscal note on what this? Do you have the savings or costs?
I know that we're having to adjust it because of the changes today.
It's been daily. You have a.
Mr. Chair, members, my name is Carrie Erber, and I'm with the Continuing Care Administration, DHS. When we did the fiscal note for the language discussed last week, it was on the previous dates, and so I'll give you what the cost was for that, and then we will have to rework the numbers to adjust for the timing differences that was put on today to delay it.
Okay, you're really going to confuse me if you do that.
Okay.
Could you just make up your best guess now, and we won't hold you to it? You know, some people think you do that anyway, but I know you're always sincere. But I just, I mean, if you want to stand away a little bit and figure out just your best estimate for this biennium and next biennium, that would be helpful. And
Okay.
I mean, within, I don't know,
Okay.
plus or minus a reasonable
number.
number.
For this biennium with the timing, the date change, it'll be about 1.67 or 1,650,000 roughly
In cost.
in cost, and then give me a second on 12 and 13.
Is that the current biennium?
Yeah. That's about the same as the government.
Okay, I had talked to Bob Meyer just 5 minutes ago, and because of the effective date change, it'll bring down the savings in the next biennium about 140,000 to about 140,000.
So there's a cost in this biennium of about 1.65 million, and the savings in the 14-15 biennium is 150,000.
140, yeah.
140
roughly.
for.
We can get you exact numbers tomorrow.
And we've not pushed hard for savings, and so that reflects the kind of the gradual nature, and there would be some additional savings, I suppose, in out years that would be considerable.
Yeah, we'll continue on.
But so that's a pretty gentle slope, I guess.
Yeah.
People in the audience should be happy about this, because there was much more savings in different versions, right? Okay, well and I realize I'm not binding you to those numbers, that just helps me understand that general idea. Questions from members about this? Senator Hann?
Well, Mr. Chairman, I have obviously not seen this before and appreciate the work. The numbers that you're giving us are approximate at this point, is that correct?
Right. The effective dates moved for the plant closures out 6 months, so we lose some of the savings that we originally calculated last week. So.
Okay.
Senator Hann?
Mr. Chairman, I would appreciate hearing some comments from maybe some of the folks who would be affected by the change and get their take on the proposal.
Senator, so that.
Okay.
Oh, and the pages 9 and 10 will be provided. We were saving. We were only saving a little bit of money. We had to spend it all. So. Anyway, so pages 9 and 10 will be passed out. And so maybe Ms. Bartolek, there's going to be a planning process, and there'll be virtually nothing closed except just something. If there's some vacant beds that are just silly to keep, are you going to close some of those this biennium or not?
Mr. Chair, we were intending to let the need determination process follow out and only use any savings from planned closures that were voluntary according to that process initially. And then the last 6 months, starting January 1st of 2014 through June 30th, we would then close capacity that currently was not licensed or not being occupied as needed to cover any remaining savings that was necessary.
All right, and you're only saving $140,000, so that's really not a lot of closures that you're expecting. And so And you're expecting they'll be coming from voluntary, and plus we're paying for some of the closures, so that eats up some of the savings as well. And so if a person chooses to close the bed, or they get a 6-month soft landing out of that. And then the mental health beds are protected under this proposal. And so as part of your assessment, there's some 300, I think, mental health beds or something like that. Is that right?
Pardon me, I'm
Is there
sorry.
300 mental health beds?
Do you know, right now, I don't know the answer to that.
Okay, I wasn't trying to stump you. But you're going to look at all the beds.
Okay, excuse me, that was what we assumed, 300.
Okay, thanks. I had a lot of conversations. I had numbers all over my head.
Yeah,
But
I didn't-
so you're going to look at all the beds in the state,
Yes.
and you're going to discover where there's been some area. You're going to start to prod some providers about. You'll discover a lot in this process, I have a sense. And is the department going to then prod providers who have been somewhat reticent to do their reassessments more often, to do those, and to get people moving on a path, and to challenge them a bit in their operations? Would that be part of your assessment?
Mr. Chair, yes, we would provide additional instructions on what to talk about during a reassessment process for both counties as well as providers to look at. And this looks not only at the capacity of corporate foster care, but if people want to move in different areas, or if we need to develop other services, or look at housing. So it's a comprehensive look at the system, as well as what to do within the corporate foster care system, knowing that there is a real need for many people to live in services that do have 24/7 staffing, but to be able to help that be targeted for people who have more of a need for that.
And then you're going to find areas that are under-bedded and areas that are over-bedded, try to right-size some of those. I know some counties say that they don't have enough, and so on. Well, that's helpful. Questions from other members? Excuse me, that was a compliment. Senator Laurie.
I'll take it as such. I'm just trying to figure out how the savings occurs in the next biennium, because, I mean, my understanding of how this provision worked, we took a bunch of savings from the plan, from the closures that came out of last session. And so if there's a savings, it's a savings above those savings that are already on the books. And so it seems to me like we'd have to, in order to generate that savings in 14 and 15, close more than we're slated to be closed by the next biennium. And I'm trying to reconcile it. This is the first I've seen this too. But I'm just trying to get to that 14 and 15 savings.
Wait, we're not adopting this today. This is
No, I know, but that's my question, though.
Yeah, we have to spend, in this biennium, we have to spend about the governor's delay money to do all this setting up. So maybe you can comment on the out years. Was there tails on this savings, or was it all one time? Ms. Bartola.
Mr. Chair and Senator Laurie, this version is buying back the reductions from before and then starting fresh in a way. So it's buying back this year's reductions, and then it's starting again. And so there's a slower period of time in order to look at the planned closures. There's no reductions. As I said, the only way to look at any capacity up until December 31st of 2013 will be if there's planned closures. That will get us a little bit. We'll have a remaining 6 months to try to meet reduction targets that are more modest. And then it will start accumulating just as the previous one did, but this is essentially buying back those reductions so that we're picking it up and starting fresh as we're going forward.
Senator.
Oh, and excuse me, the other piece it also does, and Heidi should just come here and add when I forget a piece, is it does add the developmental disabilities waiver. So it increases the number of beds that ultimately will be reduced into the future by including people who are on the developmental disabilities waiver.
Senator Laurie.
Okay, that starts to help. I'll like to see the assumptions behind it and read this a little bit more. And
sure.
Looking forward to hearing the conversation.
That's why we're doing this now, so
Yeah.
there can be. We've done quite a bit of work on the House on this in this session, and so you can't do this in a week. This has been since November. We've been working on this, and it's when we were discussing over the interim I couldn't describe what our bill did anymore because it had been changed so many times. We had to have the department come in and tell us what we had both done, and I was surprised. Where both sides had wound up. So any other questions from members? I think that's helpful for now. So you can be around if people have anything else you want to say. Ms. Hamilton, do you think we understand this pretty well? Let's take testimony then. So you're free to hang around. Ms. Aberhold and Mr. Nelson, do you want to come down? And then on deck we have Ms. Henry and Dr. Hulbert.
Good evening, Mr. Chairman, members of the committee. Sue Aberholden, Executive Director of NAMI, Minnesota. I can't, speak for all of the language, but I just really, really want to thank you for exempting the mental health beds. As you know, people don't spend a long time in them. It really is a step-down program for them out of the inpatient psychiatric unit or a residential treatment or Anoka Regional Treatment Center, and we were concerned that if we lost those beds, people would be stuck in those higher cost settings. So I really appreciate you recognizing that this was an important issue, and just want to thank you.
All right, and so, but as you read this further, I would appreciate, you're not shy to offer your comments, but but don't be shy to offer what you think. This is really definitely a work that's progressing, and I think we're getting pretty close to a good outcome. So, thank you.
Thank you.
Mr. Nelson.
Yes, Mr. Chair, I am Bruce Nelson with ARM, and this has been a long week and working through a lot of stuff, and I've appreciated a lot of folks, and you in particular, Mr. Chair, working on it. Wanted to say that we agree 100% that we need to be moving beyond the current 4-bed for everybody model. And we do need to do, as we're now moving forward with, and I appreciate the new language, with a couple of things that really are essential in making this happen. One is needs determination, to figure out the capacity. What capacity do we need? Many people do need corporate foster care now and will in the future. And what is that capacity? So that's a good thing. The other is, this is about reform. And Senator Nino and Representative Schumacher, Senator Laurie, and the two chairs have participated in a really strong effort from ARM in dialogue with the advocates and the department. So at this point in the Senate bill, there are 15 reform items. Tonight, I think there were 12 from ARM in the House bill. Tonight, you adopted some things that are going to help, are going to be the tools to help to make this happen. It's a relatively innocuous thing, seemingly, but ILS, Independent Living Services billing on a daily basis, will help facilitate this greatly. The ability to go to 25% in size and setting is a tool that people can use. It will move us forward. The shelter needy language you adopted tonight eliminates one of the huge barriers for people to move beyond with no extra cost, to eliminate that housing barrier to move into other settings. These are critical elements, and we thank you very much for adopting those as we look at the future and how we can do this. What are the tools we need to break down the barriers and to move forward? These were among those elements. So thank you for adopting them, and they will really help to facilitate this. Delaying it till the next biennium was critical. The disincentive of having upfront mandatory closings of corporate foster beds creates unintentionally, it makes the beds into a commodity. A commodity for lead agencies, a commodity for providers to hang on to, and none of us want to do that. So by passing the reforms, delaying it and buying it outright, not using contingent money but doing as you indicated, will give us a time to move forward and to do this in a planful way with good data and in a way that's going to be of the best interest to people, and it's going to free up providers and counties from having to hang on to beds because, what if I lose that bed, then all these bad things are going to happen. So we appreciate that. We want to look through the amendment more, have a question of, do we need at this point to go into the DD world? Is that critical part of this piece as we move forward into the next biennium? And so we'll look at that. We'll talk with the other stakeholders and get back to you with recommendations around that. So look forward to the next couple of days of working with you and appreciate all of the work and moving toward a common goal of reform and people being able to move into more independent settings of their choice.
Thank you, Mr. Nelson. Appreciate that. And just to react to one comment about the DD part, I think we need to. I just think we need to look at everything we're doing in the state. I have discovered in my short tenure as chair that if I look at every dollar we spend and try to figure out what we're doing with it, is this a good way to do it or not, a lot of good surprises pop up about ways to do things differently, independent of money, and they actually wind up in better service. I think you've seen some fruit of that on the healthcare side, and I think the product of this work is going to be the same. And so, especially now since there's virtually no target to save, it's pocket change. But if we don't scrutinize all those beds that are some that are extremely high cost, you understand the costs we're talking about, and so we see what benefit there is, and is this the best way to serve these individuals or not? And some absolutely yes, and some likely not. So I hope that as you chat with your colleagues that are across Minnesota and those that are here, that you'll see that that's prudent, especially given this relaxed target here. I just hope that you can agree with me at the end of this process that that's prudent. So,
thank you, Mr. Chair, and I think what we're doing tonight is going to make it happen better and faster than the alternative. So.
Thank you. Any questions? Okay, thanks. And I know you'll be around, so. And Dr. Halbert, you can come down too. But Ms. Henry, welcome to the meeting.
Thank you, Mr. Chair and members. My name is Ann Henry, and I'm with the Minnesota Disability Law Center. Well, first of all, as the previous two speakers have indicated, we are extremely grateful for a delay. This was really a very difficult cut to figure out what would happen, and certainly we thought it was defeating of some of our best programs if we would have had to immediately close beds when people left for more independence. So that is very good news. Second, we are very supportive of the need determination process, and we've been working on that all session. We think that we don't really have a good idea of where the needs are and what they are across the state, and that will give us a lot of very important information to move forward in the directions that you are talking about, Mr. Chair. We also know, though, that we have an awful lot of unmet need, especially in the DD waiver. So I am very concerned about it. I don't really understand yet. I need to look at the fiscal information, I think. But it sounds as if we are going to be adding beds to the to close to the number that we had cut last year. And that would be a concern, and I guess well, let me just give you the reasons. The DD waiver has the longest waiting list, about 4,000 people now. It is under extreme pressure because of autism, and you certainly have heard about that issue this session. It began to be cut and limited in caseload in 2002, and that happened every year through the decade except 2007. And then there were many other kinds of cuts along the way that were added to it. So, the other waivers are also under limits and under pressure. But I don't think until we have the information from gathering data and need determination that we should take the step of cutting the funding under the waiver, which is really what adding bed closures would do. It would cut the funding. And the reason I'm urging to wait on that is because of all of this unmet need out there. We have people, for instance, who are living with aging parents, and because of the moratorium, they really can't get a place, and their parents are hoping they can get set up in outside the family home before the parent needs to go into care. And then we have many people who need intensive services due to autism. So I guess my request, and again, I'm not 100% sure of this, I need to see the language and the money, would be to wait on adding more cuts to beds on the DD waiver until we come out with more next year. A report under the need determination language back from the department next February is due. What's the activity? We know there's already closure activity going on, and we're very committed to that for people who can become independent. So with that, again, thank you, and those are my concerns.
Well, thank you, Ms. Henry, while you're here. And I share a lot of those with you, you know. But I do want to remind you that this assessment is an assessment. And there's not one plan to turn one person out of the system. It's just to turn them into someplace better. And one of the things you've been encouraging us to look at is independent living and other choices. And if we don't analyze how we're serving our DD population as well as the rest, I think we're not serving them correctly. If we don't find a way to do it with less expense, we're never going to get 4,000 people into the system. One amendment I've been trying to conjure up some way to do is to capture any savings and turn them back into more slots. My good friend, Commissioner Showalter, and I don't agree on how we can do that. I feel like I've become my predecessor in the Senate, trying to find ways to capture pots of money. Senator Berglund, she would, and to serve the people that we've so much care about. But I'm convinced if we don't serve everybody in the right site, that's the least restrictive and therefore the least expensive, we're never going to get 4,000 people in. And some of the horror stories we'll be talking about 5 and 8 years from now are going to be terrible about some of those very families that you stay up thinking about. So look at, I don't know what numbers there are, but this is all voluntary in these closures. There's not one mandatory closure that I don't think we're doing here. So so some just make sense to close. The buildings are ugly and they should be burned down instead of being used, some of them, I'm sure, across the state. And maybe we should build some new ones, or maybe we should find some, you know, we talked about autism campuses. Maybe it'd be prudent to start thinking about if that's a way to do it. There's a study for that coming up. There's a proposal in the Senate which may turn into a real serious look. Is that a way to go with some of these other needs? And so, but I think the time when talking to the Fraser Group and other people that cautioned us about going to 4 off of the 8s and what they had before, that would cause actually some harm to the services. I think they're correct. They said it would cost more and be less good. So and they're not people that were mean to their clients. They just, and so I think it's time to look at our model from the bottom to the top, and I hear you saying that, and I understand the cautionary note, but I just want to encourage you, as a philosopher in all this, and as the, you know, next year's coming, and the forecast right now is $1.1 billion to be short. What are we going to do then? You know, I hate to think about that. I'm hoping that the increases keep coming in the budget. But at least we want to make sure we're paying for the right things for the right people and at the right place. So I know your passion, and I appreciate that, and I'm trying to encourage that and keep us working together. So you can react if you like.
Well, Mr. Chair, I guess I want to be sure that I'm being clear about this. We are not saying that we should not assist people to become more independent at all. But when people do become more independent because of the pressure on this program for the last decade, we're suggesting that those resources that are freed up be used for people who are in queue, whose needs are very high that we haven't been able to meet. I definitely want people, as many as possible, to use less resources, because I, too, agree we have a lot of unmet need and we're not going to get a lot more money.
Yeah. So I'm frustrated with that second part as well. So, well, very good. Thank you.
Thank you.
And welcome.
Hi, Alice Hulbert. I'm a parent of a severely autistic young man who's currently living in a group home. So I've been following this legislation, and I'm really happy with the changes that you've made tonight with delaying the cuts and doing away with the automatic cuts related to people moving into the community, because often those people are coming from very successful programs, and I don't want to see a system that harms and punishes good programs who've helped people become more independent. I understand that there are now no targeted savings, is that correct? So the $2 million, the $4 million was reduced to 2.1, I think, so now there is no set target for this year.
The $4 million is reduced to nothing.
Good.
Actually, we're spending, I think we're actually spending money. We were, there were some interactions. We had, I think, a $2.5 million net savings. And now we're spending $1.6 million. So I think it's a swing of all that. Because I think we had, in the line items, we had to buy it back, and then we saved. And I knew the $4 million wasn't there. I thought there was $3 million. So for a net of 1.7, I think. But that's not present at all. So it's a swing of $3 million in reality. So
This is good, all good news. And I like your philosophy of trying to capture those savings and convert them into new slots, if there's a way to do that in the future. I still have concerns about allowing a fifth bed, which is, I think, just in the Senate version. And as a person who has someone living in a group home, I can say it would be extremely disruptive to have a fifth person moving in, potentially 24 different people per year is what's allowed by the law. I think that's a little bit over the top. And I think that with the new models that are being developed, there's probably room to develop respite beds within some of those new models, rather than trying to shoehorn it into group homes where it doesn't sound like it's a very good match for doing that kind of programming. So I also wanted to understand a little bit more about the new needs determination process. I think the original one was only going to assess the needs of people who were currently in foster care settings, and then it was amended in the Senate to actually assess the needs of all people eligible in the state for that service. And so I assume that is how we're going to look at the, or is this up for debate yet?
I don't know that. We can actually find out.
You'll be discussing. All right. Great. Thank you very much.
And let me just, I hope you don't mind dialogue with the witnesses like this. The fifth bed, I think in the proposal is 120 days in a site, if that's where the language is at. And it's actually it accomplishes two things. If we're lacking buildings, it gives some, the respite beds are people who are trying to care for their own child or a family member, and they actually want to go on vacation sometime. If we don't look after those needs in a way that actually we can afford and that's practical, the family situation will degrade markedly, as I've heard awful tales. And so providing this as an option gives some respite to those families so they actually can do other things and tend to the challenges.
Oh, yes.
And I believe the language is permissive, but some buildings have way more room than 4, and bringing a fifth person in there would be so easy. It's just ridiculous, and some have no space whatsoever. But this is a way to help the providers actually stay in business in a time when they haven't gotten an increase since they can remember, and we keep reducing their rates this last time by 1.5 points. And other reductions that happen to some. And that's the practical challenge. And so the challenge we face now is how do we practically care for individuals that we care a lot about in a time when finances are there's a lot of money we spend on this, and actually more every year. But when there's less resources than we would like to have to accommodate some needs, that's a challenge. And so as you look that over, I hope you can consider the big picture about that and see where we can safely do that and maybe create some options on the part of the residents. And some people should never have a fifth person come in because they can't handle that change. And some residents would probably enjoy the company. So help us with that, if you will. So
Right.
You can react to that if you want.
I agree. I think, there are many settings where it could work. I think it's the permissiveness of the language that's the difficulty.
Well, we'll keep.
And it always is.
Yeah, and so this is the committee that decides that, so we're open to that advice. So, thanks.
Great, thank you.
Maybe Heidi or Alex, do you want to come down and just answer that question about the needs thing? If it's just in short, it's getting late, but this is a really important topic. So, if you want to react to anything you've heard and then comment about the needs analysis, et cetera, what's the short version of what you're planning to do?
Mr. Chair and members. There's two components. One is around a gaps analysis. This is building on something that first was initiated in 2001 as a result of the Long-Term Care Task Force on really trying to look primarily in the area of aging, of what communities offered from transportation and housing and medical care as well as services, and then go through a process of making sure that services were developed that would better meet people's needs. And so there's language that expands this gaps analysis process to people with disabilities, including people with mental illness, to take a very encompassing look. And what's nice about this is that regions or local areas are participating in it so that they can really look at the strengths of their own communities and what they need in order to develop. The need determination process is a component of that, and it says for the service of corporate foster care, where are we using corporate foster care, who's living there, who are the providers. It's really understanding more details around the types of services that are being provided to better say, are there people living there, for example, who have said they wanted to live in another part of the state? Well, can we help them be settled where they'd like to live? Or we might find that there's gaps where we need some more providers with specialty services, and that's a way then of helping to promote people who might be able to move out and then develop those services to meet specialties. So they go hand in hand.
And will it include the waiting list people as well, or is that not so much?
It will include the waiting list, it will include people on the program, and it also, the gaps analysis includes private pay. So we look at census information and to also help people look at that so that we can help prevent people from needing to get on medical assistance in order to get some of the services that they need.
Thank you. And Ms. Abdul, do you want to come down? Welcome to the committee.
Hi. Thank you, Mr. Chair and members of the committee. My name is Aidal Abdul, and I wasn't going to say anything, but Ann had said something about autism and a couple of people before that, and I have a son with autism, and as many of you may know, there was a CDC, Center for Disease Control in Atlanta, released the beginning of this month, April 2nd, that autism has increased. It is now 1 in 88 nationwide, and it's probably more in Minnesota. And there was also to talk about there's 4,000 people that are on the wait list for the DD, because that's most likely what children or adults with autism get. Now, as a mom and also as an advocate on the Minnesota Autism Task Force, and I've just also been appointed by Secretary Sebelius to be on the National Autism Committee to advise her about autism services. I think as a state we're really behind. We don't have the autism specific Medicaid waivers. DHS can apply that. That would be in addition to the home and community DD waiver. So for example, if we had that, like Wisconsin has it, Ohio has it, Utah has it, Colorado has it, there are states that have this, and then the children that have autism, because early intervention is the #1 thing. We don't have a cause, we don't have a cure, but we know that the earlier a child gets services, the better off that they are, and the more that they're likely to become tax payers rather than tax receivers. So I really encourage our state to apply for, or look into it, at least talk to Cindy Mann, the director of CMS, who's very willing. I've harassed her enough to talk to us. She wants to help us and make sure that our state is proactive, that we are paying services for these children in a way that is cost effective, that is based on quality, and that we have services that are compatible with other states. You know, when you have a child with autism, it's like hitting a dart. You have no idea. You don't know what services work. You don't know what treatments to go. You are on a wait list forever. So if we have a method and various therapies recommended by NIMH and CDC, and we say this is how much we're going to pay from birth to this age and then to adulthood, then it releases the numbers. It eases the numbers that are people that are on DD waiver, because DD is for all disabilities. So I urge DHS to take autism seriously. I urge MDH to take autism, the public health crisis that it is, and be more like other states. I hate to pick Wisconsin again, but they're so proactive. They're doing autism research. They're collaborating with their university. They're collaborating with the CDC and NIMH. And we have to figure out what's causing this. We have to figure out how do we prevent it, because otherwise it's going to bankrupt us. It's not easy. It is a 24-hour job. It's like walking needles on fire. Thank you.
Thank you. Okay. Well, thank you very much.
Thank you.
Appreciate coming down. So that's the presentation on this piece. Is that clear to members? I think you can kind of get if you've not spent much time on this, wherever you've been doing other time, but you can see the complexity of this and the sensitivity. So thank you for that. Let's move to our next topic, which is the patient consent for records. Is the Department of Health here? They want to come down. Okay. Now this is right. Well, this is in the bill. This is in the House side. And Ms. Cleveland, can you tell me where this is in the bill so people can? I think there's two parts.
Mr. Chair, it's in Article 2, Sections 14 and 15 of the House language.
Thank you. And while she's coming, let me just tell you, this is provoked by me. I've been part of this record sharing discussion since we got into record locator services and the whole push toward e-records. Currently in Minnesota law, you can get your records released if you have a wet signature authorizing that, if there's statutory requirement like in work comp, you can get records released, or if someone affirms they have your permission, which is real handy if you're doing electronic records. You can just push the affirm button and then off go to records. Already in the system, if you have a record locator service, where records are becoming populated more and more, it'll list the various places you've been, what clinics you've been to, without any detail. It'll say you've been to, Red Rock Clinic, and you've been to, some maternity center or whatever. And even looking at those titles, you can often know what the person's had for care. If it's like, Mount Pilot Mental Health Center or Orthopedic Fix-It Back Surgery Center, or some Red Door Clinic where they do public health services for people who have various needs. And that to me is already interesting that that's known and that can be accessed with by many tens of thousands of individuals who are health providers. What this piece attempts to do but if you wanted to get access to those records, you could affirm that you have the right to do that. And it's easy to have a lot of fraud in that. And there's not any reported because nobody keeps track, and you're not notified when your records are accessed. The way electronic records are building, it's getting more and more to be the commonplace thing. It's a matter of time until anybody in this room has their records accessed by the boyfriend of some nurse who somebody gave $100 to, and they start to penetrate that safeguards. And it's against the law. It's a crime. But there's no way for you to know if anybody's checked your records unless you go check on your own records. If I have somebody who logs on my Facebook, if I log on my Facebook from a different computer, I get a little text saying that somebody logged into my Facebook. My Facebook, for heaven's sakes. But on these records that talk about your pap smears and your prostate situation and how your lungs are, very private data, there's very little safeguard. And so so people lie, sorry to tell you. And people are fraudulent. And my effort in this work has been to narrow down who can affirm that they have the release of your records. And I think there could still be some improvements made, but that's what's in the bill. There's some concerns yet, and I respect those. But I think the problem is that we are sitting ducks as a state, individuals waiting to have our data access. So that's the challenge. And so welcome to the committee. And I did work with you all trying to get some language improved. The first version was not nearly as good as the current one. And so could you comment on anything you want to comment about that?
Certainly. Mr. Chair and members of the committee, for the record, my name is Diane Rydrick, and I'm the Director of the Division of Health Policy at the Minnesota Department of Health. I would say really we're just here to answer questions, and we can provide comment if needed. As you noted, Representative Abeler, the original language in the bill was substantially different from what we have currently, and it would have limited the use of representation of consent to only cases of medical emergencies, which the department and a number of providers had concerns with because there are already rules related to consent and the lack of a need for consent in medical emergencies where a patient is by definition unable to provide that consent. And so upon your request, we did provide some technical assistance to address that contradiction in the language and to address your concern that records could be accessed for uses other than treatment, which is what the current language does. It allows the the use of representation of consent for purposes of treatment, payment, or healthcare operations. Our intent with providing that assistance was really to acknowledge that the use of representation of consent is certainly much more broad than just cases of emergency. Again, those are cases where consent isn't needed. We are in support of a robust system for exchange of clinical information, and we are concerned that limiting representation of consent can set us back as a state in doing that. My understanding is that there are some concerns still with the current language from providers and payers who I believe are here to testify about it tonight. And so I think I would leave it to them to provide some more details about their concerns with what the current language does, and then we can be here to answer any questions.
All right, and from the department's point of view, if this were to become law in this form, you would be neutral on that?
We are comfortable with this language, and we are comfortable if this language is removed.
That's fair, yeah. I thank you for that.
Mm-hmm.
So I think I said it pretty close. Thanks. Any questions for the department? Thanks. Thanks for doing that. And we have an array of witnesses, Mr. Griffin, Ms. Krinke, Mr. Renner, and Ms. Brace. And so you can just, maybe two can come at once and offer your advice. Mr. Griffin, welcome to the committee.
Thank you, Mr. Chairman, members of the committee. For the record, my name is Phil Griffin. I am representing Preferred One, a nonprofit health plan here in Minnesota, owned and operated by Fairview and North Memorial Hospitals and a group of physicians. And I'm here at the witness table with Mr. Renner from the Medical Association and Ms. Krinke from the Hospital Association. And Mr. Chairman, with all due respect and members of the committee, Article 2, Sections 14 and 15, the patient consent for release of records, is a provision that still brings concern for our groups, and we think for other people. And while we appreciate the Chair's explanation of what he is trying to do today, we also believe that this language will interfere with the ability of organizations like ours to move data in ways that you're asking us to move as we move towards new systems for payment. And Mr. Chairman, I don't want to belittle the questions that you've raised here on what might be happening and the possibilities. It is impossible for us to prove a negative, that nothing bad will ever happen. But I want the committee members to know that the organizations that are in front of you today take very, very seriously the privacy of the data that we're working with and work on a constant basis to make sure that that data is there. But in addition to the concerns that you raised, Mr. Chairman, I want to raise concerns that I have individually about the ability of having that data available when it's needed, whether it be an emergency basis or whether it be for some kind of new payment system. I'd like my data to be available and moved around. And quite frankly, I have not seen the examples that you have given to us this evening as real threats to the privacy system. And in fact, I would suggest to the members of the committee and yourself, Mr. Chairman, that the ability that we have for security on medical records currently in the electronic world is much greater than it was on the paper system that existed in years past. Mr. Chairman, I won't go into great details beyond that, but let me say that for the organizations that I'm speaking for, which includes the Minnesota Council of Health Plans, we believe that this language is unnecessary, that it will interfere with the ability that we need to kind of move forward in new kinds of payment systems, and we would respectfully request that these sections be removed from the bill as you move forward. Mr. Chairman, I'm going to turn to Ms. Krinke to give you a couple of examples of things that are going on with her members.
Welcome to the committee.
Thank you, Mr. Chairman. And for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. I always get nervous when my phone rings at my office and I start hearing from the lawyers who work for my various members. And so when they start raising their eyebrows about concerns they have with language, I take those concerns very seriously. Because they don't get concerned about a lot of stuff that we do over here. So when I do hear from the attorneys, it makes me pause. I just would like to share a couple of examples. I know that our members are doing some very, very innovative things right now out in the community coordinating with social services, not just for medical treatment. So sometimes we share data, once we have patient consent, outside of just treatment situations. And you all may recall the work that was done last year on the InReach project, which was down in Owatonna, where the hospital worked with Steele County, and they worked on social service issues, not just medical treatment issues. And we have the Regions Hospital, located here in St. Paul, has been working on a program called Hospital to Home, and they were finding a large number of folks who perhaps use the emergency room inappropriately. They noticed that this population oftentimes was homeless. And if they could start working with Ramsey County on social services for homeless folks, they could reduce the use of hospital emergency rooms. So I just mentioned those two innovative programs because we are thinking about how we can use data and information in creative ways to help bend the cost curve. And so we just have to think about the changes, as Mr. Griffin said, about how we can use data with patient consent, but we don't want it limited to just medical treatment, operations, and payment. I just have one other little example that I would like to mention. If we don't have patient consent, right now, we would have to then bill the patient directly. And we bill the health plans right now sometimes without having assigned patient consent. So there are times when we proceed with data sharing without having patient consent forms signed. And one of those is billing insurance companies. So thank you, Mr. Chairman.
Well, Ms. Spring, if maybe you haven't seen the new language on 4213, it talks about payment and health care operations. So that's not persuasive to me. And so nobody doesn't want you to get paid. But, and, you know, the InReach thing, we can add a term that allows that to be for, you know, homeless services or something like that. But what you haven't persuaded me about is fraud. And I don't doubt that, and Mr. Renner is going to offer some similar comments, which I'm happy to hear, and he'll get his chance. But you haven't told me about how somebody's going to sneak in there or by virtue of being a dishonest employee is not going to get that data out and give it to somebody for a price. This is going to become valuable someday. And in 10 years or 5 years, you're going to say, Abeler was right. And I'm not being paranoid. I'm just saying how it's going there. And so, because this data is available about everything about your history, Ms. Krinke, and it's accessible to 100,000 or more people. And so that's what I'm after. I'm not worried about what a hospital does. And I'm willing to almost exempt hospitals in care of their stuff. But I want to find a way to have less people who are dishonest have access. I'm not going to get 100% because if I do, I'm going to shut down your work. But there has to be a way to minimize the exposure of these innocent people who have no idea that their data is waiting to be exposed. So that's your homework assignment. So and if you want to comment about that, you can.
Mr. Chairman, I don't know that the language that's in the bill as it is now quite matches up with what I think you're trying to get at. So.
Well, this is the best version. I don't like it either that well, but it's the department offered it, and it seems to address many of their concerns. But I think you have to acknowledge the problem is there, and it's every month you read about some laptop got left laying around with somebody's tax information, which is all private and locked up somewhere, and suddenly it's on a laptop. Somebody would have an access code they'd leave laying around, and somebody would steal it from them, and they would log on and get data out. And it's going to be a matter of time. That's all I'm saying. And so you want to know that, and it's too expensive to tell people to feed back with a little text message that somebody accessed their data. So that's the problem. Maybe I didn't make the problem clear to you before, but that's what I'm trying to fix. So you have bright lawyers. Ask them how to do this. I think you're going to be sorry someday. So, Mr. Renner.
Mr. Chair and members, Dave Renner with the Minnesota Medical Association. First of all, let me, again, I agree with what much has been said here. I appreciate the problem you're trying to address, and I appreciate the changes you've made in the language, because earlier versions definitely created some concerns. I still have concerns, however, for similar reasons as Ms. Krinke, when I hear from health law attorneys who are smarter than I who are saying we're not certain if this works. Whenever we get into the issues of data of medical records and uses of medical records, it gets very complicated, and what we are concerned with is unintended consequences. I think the issue that you're trying to address, as I understand it, is fraudulent access and fraudulent use of this data. However, my fear is the language you're putting in here is not addressing the fraudulent use, but instead is limiting potential appropriate use, unless it meets one of these three criteria. And again, I don't question your motives and your intent and what you're trying to get at. I think it's just whenever you get into medical records issues, it gets very complex because there are other state laws that potentially may conflict or may create unintended consequences. We share the concern about data privacy, as Mr. Griffin said, and I think the fact that these three organizations are sitting at the table together, you don't see that very often, I think is an indication of the concerns that we have of what potential unintended consequences will come out of this language.
Mr. Chairman?
Person Kiffman.
Thank you, Mr. Chairman. You know, I take a look at this and recognizing that the patient data belongs to the patient. It doesn't belong to the hospital or to the provider. It's the patient's data. And that's fundamentally what I see is really important here is protecting that. But I take a look at this and I think of what other uses are you saying you'd use this data for? Because it says here, treatment, payment, or health care operations. What is missing that might be another additional word here that would be helpful to you? But I look at these and I look at the comprehensiveness of this treatment, payment, or health care operations. As anybody here in the room is a patient, what else beyond that would you want to use this data for? And maybe that would be helpful to have that answer.
Yeah, whichever one of you.
Mr. Chairman, Representative Kipner, let me just back up a little bit and say that I'm not sure I agree with your analysis under Minnesota statutes that the medical record belongs to the patient. Certainly the patient has access to both clinical and hospital data in their medical record, and we've made that very, very clear under Minnesota law. But the control over the record really actually belongs with the provider, and that really is something that we need to be very clear about. The patient doesn't get to change their medical record, with the exception of some very small things. And I think we want to make sure that we maintain that so that the record has the integrity of being a medical record. But the question of what the data gets used for and how it gets used is not a small question. And I think Ms. Krinke gave you some ideas of some very innovative projects that are going on. But I can give you examples from one of my other clients, which are the FQHCs, that work with people in a variety of settings. And these are not only healthcare issues that they're dealing with, but social service issues that impact whether or not people actually get healthcare. So those issues surrounding transportation issues for people that are trying to move patients back and forth may not be what I would call healthcare operations, and I certainly don't think they fall within that. And so if a patient doesn't get to the hospital, doesn't get to the doctor, doesn't get that treatment, it doesn't do any good to have the availability of plans or providers or drugs or whatever else we're using in the system. But if I could go back, Mr. Chairman, if that answers Representative Kiffmeyer's question, I'd like to go back to your original question, and that is the issue of the integrity of the data and making sure that it's kept private. And I want members to know that we don't just have computer systems where you have somebody in the back room making up a quick algorithm and a password that's their birthday or something small like that. We really do work hard at making sure we have algorithms that protect the privacy of these systems, that they're constantly changed, that they're updated, that we are working with the providers that make the kind of healthcare software that we use in our computer systems. And these are amazing systems, as you, Mr. Chairman, were describing to me. You had a chance to visit one of the local vendors here recently about what they're doing. These are very, very complex systems that we are working very hard to make sure that that data is protected and the privacy is protected. Is it 100% nobody can ever get into it? We all know the kinds of attacks that are taking place in cyberspace. We hear about them in the news against our government, against our military and others. But we understand those things are going on and are constantly working with our vendors and with our staff to make sure that they're trained properly and understand this. There are evil people out there, Mr. Chairman. You and others have watched me work around here for the last year and a half pro bono on a case dealing with Mr. Petters and the evil that one person can perpetrate on society. Those evils have gone into a lot of places and hurt a lot of people. We can't prevent all evil, and I don't think your language can either, but we can continue to work together, and I hope we will continue to do that, but I don't think this language gets us there.
I appreciate that. Representative Kiffmeyer, is that good?
Well, I want to go back to this fundamental philosophy that talking about whose data is it, I think you have a duty and a custody without question, because it's also the doctor's record of his actions and his behaviors, or the hospital record. I certainly understand that. But you need a signed and dated consent from the patient. So obviously, there is a situation here that the patient has. And matter of fact, one of the benefits of an electronic record many times has been patient getting an access to look at their own record and clarifying errors that may be on that record, either by miscommunication or something like that, or for me as a child thinking I was allergic to pears. No, I just got flu after I ate pears. Nothing to do with pears. The pears are fine. They're wonderful. But in my mind's eye, I told everybody, are you allergic to anything? Yep, pears. Ridiculous. Not a huge thing, but they might have even said, not really, but whatever. But I do think that there is a shared duty, and you have custody and responsibility, but if it wasn't belonging to the patient, you wouldn't need a signed and dated consent from the patient. So I just want to make that clear. I think the issue, a comment you made before was that sometimes now the electronic world and the control and the access is sometimes more strict. That's really true. On the other hand, when there is a breach, it's big. And they get a lot more than usual. And so it is really, really important in the electronic world to have those security and those parameters around it. But if you don't know security's been breached, you can't really ever correct it. And so, again, in this kind of a situation, I think that's what it is for me. But I think that what we're trying to do here is come up with that solution, and so far I've heard of the issues or your problems or your concerns, but my specific question is what words could we add to this that would help give you the legitimate scope that you might need to do that legitimate work, such as social services or something like that. But I get concerned when it starts becoming so easy, and then you go down the slippery slope, and the patient is not strongly enough considered here. So I know we're going to work on it, Mr. Chairman. Not going to happen tonight, but wanted to clarify that.
Thanks. Representative Gotwell.
Yeah, I know it's late, and I don't want to belabor this too much, but I did want to weigh in to say whether we do this language in this bill or not, in the time that I've been around here, I respect completely the need for electronic records. It's the way we're going. It allows for appropriate access, especially as we talk about things like telemedicine and so forth. It's going to be vitally important that we have that. And I know that providers are setting up secure systems. But what the message typically from the provider community is trust us. If I can kind of paraphrase in real broad terms, it's trust us. We're doing our best. We got great systems. Trust us. And I think what I hear frequently is, yes, trust us, but this is sensitive data. I think Representative Kiffmeyer covered some of it, Representative Abeler. But is there a way? Can we at least be working on it? Some way. I like the idea of if somebody accesses my medical record, am I notified somehow? Oh, okay, my doc accessed it, or somebody in an ER accessed it, and I know about it. That's good. It doesn't seem to me that would be that difficult to do. Maybe it would. I don't know. But there is this yin and yang between providers owning records and trying to do their best for their patients, and still trying to recognize that this is sensitive data and patients' desire to know when it's being accessed. And I don't know where the middle ground is. I don't know that this language gets us to that, but I do think we need to have more than just to trust us.
And Mr. Chairman, from the Medical Association's point of view, I think we would agree with you. And I don't think matter of fact, we would argue that our medical records laws is stricter than even HIPAA's federal laws because of the concerns legislature raised. I don't believe, however, the language that is in this bill does what you asked for, Representative Gotwell. This doesn't in any way notify you if somebody is in. So I think this doesn't feel what I hear the concern is.
Mr. Griffin, do you want to say something?
Mr. Chairman, I just would reiterate what Mr. Renner said and say that to Representative Gottwald's point, I'm not asking you to just trust us. I'm asking you to work with us to try and verify those kinds of things. This isn't just data that we have. This is data that the state has, whether it be related to CGIP, whether it be related to Medicaid, whether it be related to PMAP. We all need to be working together on these kinds of things. And we're certainly not suggesting that you say just trust us. But we are working with what we consider to be the best and the brightest in IT world to come up with these kinds of protections. We have what we think are the best systems available, and my client preferred one as a beta test for the software vendor that we use. We'd be happy to challenge that system up against what we consider to be antique mainframes and systems that are antiquated in terms of what we're doing. So I don't want to say that this is something that's just trust us, we're not doing it, but we'd be happy to work with you. My comments to Representative Abeler when he and I met, and we spent probably more time than he wanted to discussing this in his office a couple of weeks ago. And my poor intern was sitting there watching it like ping pong going back and forth as she got her education. But I keep saying I need to see the examples of where the harm has really come down. And while I have heard anecdotes about stolen laptops and some of those things, and we use laptops in the systems for lots of things, whether it be the nurse practitioner that's at the assisted living facility with my mother when I met there yesterday, or whether it's people doing auditing that come in to do our books and move laptops around. But those systems we also make sure are secured, and that there are algorithms on that data so that even if the laptop is stolen, somebody opens it up and hacks into it, they can't get into it, and if they do get into it, they get into data that they can't use.
And just to, there's one more witness, but just to this, and then you guys can go. No one's concerned about the health plan's office, but I'm concerned about a health plan angry employee or somebody who, for some kind of gain, it'd be money sometime or some other benefit, is going to not hack in. They're going to access using their code. And no one's going to know for a year that they got your data about your health plan, about your information. There's no way to know. And if they use the company computer, perhaps, but not if they log on from home out of this site. And or our clinic has pretty mediocre equipment, but at my clinic, it's not impressive, but it works for our work. Low tech. You worry about the low tech sites, the nursing homes. Some of the providers who are here doing their home care stuff have an access right to get to some of this stuff. That's what I'm worried about, not you guys. But so then that's the problem I'm bringing to you. So this may not be the answer, but I want to make you own the problem. And so when you come here and you talk us out of having some safeguards, and later it happens, then the people who deny the problem will be those who have to own it. I'm just telling you that. So we'll talk some more. Ms. Brace, do you want to come down?
Thank you, Mr. Chairman.
So help me out here if you can. So. And then we're going to talk about fees next. So everybody wants to stay for that. So, Ms. Brace, welcome to the committee. Hope you enjoyed the discussion.
Yes, Mr. Chair. This is Twyla Braze. I'm president of Citizens Council for Health Freedom and have done a whole lot on the privacy issue over the years and know a lot of what Representative Abeler is talking about. So I'm going to just say I have 3 little sections here. The first section is just to talk about the language in the bill, and then the second is just to adjust what you have said. We do appreciate your comments.
Well, that's the language.
We do appreciate Representative Abeler's concerns and his comments. The thing about the language in the bill that I want to point out a few things here. One, representation for anyone who happens to be listening to this and doesn't understand. Representation isn't actually a signature. It's just a representation that someone's got a signature. The second thing is that there's no definition for payment, treatment, or healthcare operations. I'll bet that every one of you has some idea about what you think that is. But the fact of the matter is there is no definition. What we do know is there is a definition for payment, treatment, and healthcare operations in HIPAA, which we call the no privacy law. And the payment and the treatment and healthcare operations are broader than anybody actually thinks. As a matter of fact, healthcare operations is, I believe, if I recall correctly, 306 words long. And every part of that definition could have another definition under explaining each one of those things that are in the definition. So it seems to us that you are bringing in, as much as I understand what you're trying to do, it does seem to us that you are bringing in what we consider controversial HIPAA language, and we do indeed have stronger language here in Minnesota than in the federal law. And so by bringing this in, we're not comfortable with that. There is also nothing to require that patients know what they're signing, because they have their own idea, too, about what payment, treatment, and healthcare operations is, and there is, again, no definition. So that's the language part. Now, I found Mr. Griffin's comments interesting in particular, and so I thought I would just give a few little facts here from some studies, namely that a variety of studies, 80% of healthcare organizations have reported one or more breaches. Most breaches are inside jobs. The HHS reported, I believe it was 7.2 million breaches over a 2-year period. And the latest statistic, I believe it was in January, is that it cost $7.2 million per incident. In addition to that, you may recall that in January, the Attorney General here sued Accretive, I'm not sure how to pronounce it, which was a contractor of Fairview, for the fact that they had lost a computer with 23,500 patients in it, and her lawsuit alleges that they gained access to the sensitive data through contracts with the hospitals and numerically scored patients' risk of hospitalization and medical complexity, graded their frailty, compiled per-patient profit and loss reports, and identified patients deemed to be outliers. This debt collector, which is who they are, found a way to essentially monetize portions of the revenue and healthcare delivery systems of some nonprofit hospitals for Wall Street investors without the knowledge or consent of patients who have the right to know how their information is being used, said Attorney General Swanson. So that's the third part, and I do have to say that I think it's very interesting that Mr. Griffin said that our security is better today with electronic than it is with paper, because I would love to see how people could take 23,500 records out of somebody's office and cart them away so readily as they can on a laptop. So the third part I want to talk about is just trying to get you to your goal, Representative Abeler. And so I recall that your language did talk about in an emergency, and we've never liked this section. We've never liked the representation, but we know why people who have electronic medical records in their systems like that. So we would have preferred at that point in a documented emergency, and then at the end it would have said solely for current treatment, so that would be the only reason why there would actually be a release under representation, and we thought that release should be documented for the patient to know what happened and by whom. And so you could also add language that says the details of this release shall be documented and shared with the patient, and that way the patient actually knows what's happening. Another idea, of course, is to require consent for online interoperable electronic medical records, like some other states do, which would also help you deal with what you're trying to get at. And another one, which I think the health plans haven't, or the hospital systems haven't talked a lot about, but if any of you have been to your doctor as of late, you may realize that there's about 9 different things that you're consenting to with one signature. And we find that very problematic, and most individuals aren't even going to know, and they're going to sign it, and they're going to allow all these social services and everything else to happen. And finally, to get to your idea about people should know, back in the record locator service day in 2007, we actually tried to get a requirement that patients could get access to the access log, and we're unable to get it. And we still think that should occur. So those are my comments, Mr. Chair.
I think I like the access log idea. I've given up on the consent thing. I tried in 2007, and I appreciate that. Any questions for Ms. Brace? It's late, but I appreciate your comments. Thank you. Well, thanks for that, and it's getting late. We have one more topic. I thought we'd be done around 10. We're hitting that. Mr. Kerber, you want to come down? And so actually on this last topic, I'm open to advice. So I thought it was a productive discussion, and I think it's not a small matter, so you've already heard that from me. So, Mr. Kerber and Mr. Nelson, there's a piece in the House bill, I think. No, you're staying here. Oh, you're giving the room. Oh, so polite. So, Mr. Kerber, in the bill, I think there's some House language. Can you tell me where it is?
Mr. Chair and members, I'm Jerry Kerber from the Department of Human Services. I think the language you're looking at in the side-by-side is on page 4 of Article 4, Section 6, House-only language that's talking about fees. What this was about, Mr. Chair, should I just give a little background of what's going on here?
Yeah, go ahead. Sorry.
Okay.
This is better tonight, but
this
go right ahead, take your time.
This is all related to a CMS determination that the Department of Human Services needed to make some changes in how we oversee some of our Medicaid services under the home and community-based waiver. And these are services that are not currently licensed. It's about $2 billion a year that we're spending roughly on these services, and what they were finding is that there was inconsistency, and this is the kind of thing the committee's all heard, but there was inconsistency in the rate setting, and there was also inconsistency in the standards that were applied to these different providers for these services. And so the approach of the department in a correction plan is sort of twofold. One is to come up with a new rate setting methodology, and there's been a lot of discussion about that, and I think there's been some settlements, and there's a lot of people are working on that. This, however, is more related to the consistency of those standards for the services provided. And the approach that was arrived at was to come up with just a very basic level licensing arrangement. CMS had determined that the county oversight was too inconsistent and it needed to be implemented in different ways. So what we came up with is a state-operated oversight system that would be carried out by the licensing division of the Department of Human Services. The costs were not huge. I think we're going to have like about 4 licensing staff that would license about 1,000 programs around the state. The original proposal included not just language for those licensing standards that we had worked on with a variety of stakeholder groups, but also some licensing fees that would fund it. The way the licensing division and these activities are funded now at the Department of Human Services is as an enterprise where we collect a fee that recovers actual costs for doing this work. And so it was budget neutral, but there were fees that were involved in this. And so that wasn't so popular. And so what we have remaining is some amendments that are pushing the dates out for the effective dates of those provisions in the language, because we're really still hoping that those language provisions will be adopted and passed into law, so we can show CMS that we are moving forward on getting to the point where we have consistent statewide standards. But then over the interim here, we'll be working with stakeholders and come up with another approach for how we're going to recover these actual costs through fees. There's a finite number of ways that we can do it, but we'll come up with a number of different scenarios, and we're committed to working with provider groups, and there's some language to that effect that's going to be hopefully amended into the House version of 1675.
Yeah. No, and you can ask questions if you want to, but it was there. You had talked about a number. Rulemaking takes a long time and it's expensive, and you'd rather not do that. It takes, a year or something, and $300,000 to do this kind of a rule to generate $700,000 or something worth of money, which seems like not a productive way. There was some other version you had that was an $81,000 way. What's your best advice to us now from what discussions have been? The work group idea for small money, or what was it?
Mr. Chair, our recommendation at this point is that what we do is sort of piggyback on the other stakeholder group that's going to be working on the rate setting. Because we have a little bit of time here, we hope to come back with a fee structure next year, proposed fee setup. But we hope to use the existing stakeholder group, they'll be working on the rates, because it's the same providers, essentially, and same stakeholders, and have those discussions with that group. And you're right, we had talked, Mr. Chair, about proposing rulemaking, but that was about $120,000. And I think the two concepts that we wanted to respect were that we know that there's an interest in having the legislature set some of these fees as opposed to them being set in rule. And also we want to make sure that we can demonstrate that we've reviewed these fees with those who are affected, and we've come up with essentially what's probably the fairest way to recover actual costs. And so to do that, we're hoping to just kind of piggyback, as I said, on that other stakeholder group.
Would there be a cost for that?
Mr. Chair, no.
Senator Hann.
Well, thank you, Mr. Chair. I know we had some discussion about this in a meeting we had last week. And I appreciate the desire to create standards, and I understand that today counties have varying ways to determine who should be qualified. But why does the desire to create some uniform standards turn into a licensing regimen and fees? Why can't the standards be established? And what is the relationship in your mind between trying to set some standards that are uniform and applying those, and then turning that into a licensing regimen? What's the relationship there?
Mr. Chair and Senator Hann, I think what the licensing does, I think when people are talking about developing standards, there's an expectation that there's some kind of oversight, there's some kind of monitoring for compliance with those standards. And especially, there's $2 billion at stake here, and so are these services being provided, and are they being provided to the right people and in the ways that we think we're supposed to be receiving those services? And so rather than create something separate from licensing, I mean, there was discussion about should we call it certification, should we call it registration, what should we call it? It just seemed to make more sense to call it licensing. And if we call it licensing, we already have a lot of infrastructure in place that deals with licensing activities. We've got systems, we've got language and statutes that talk about, what is our access to those services. We have other language that talks about, what are the criteria for taking an action against a provider? What are their due process rights? Is it fair hearings? Is it contested case hearings? And timelines. We have a whole infrastructure that's set up that seemed to kind of make some sense here, that we just sort of move this over to that setup, if that answers the question.
Well, appreciate that. Any thought at this point about current providers that would no longer be qualified under a licensing regimen? Has that been something that you've looked at? And are we going to have a number of providers that are currently eligible to provide services no longer be eligible under the licensing structure?
Mr. Chair and Senator Hann, we don't think that's going to be the case. I mean, for a couple of reasons. One is the licensing standards that are proposed in the bill are essentially the expectations that were most common in county contracting, and those expectations that are required for somebody who is enrolling in provider enrollment to be reimbursed for services. So there's very little in these standards that's new, and I think providers may verify that. There's a couple things where we got a little bit more clear about medication administration and what kind of background do people have and what kind of training ought they have if they're going to be giving more of the serious medications, IM medications, subcutaneous, those kinds of things. And so we have the standards shouldn't be different than what they're familiar with. And then to the other issue, one of the things that we worked a lot on is the first licensing visit that people get. Well, first, backing up, there's going to be some training for providers. The department is committed to providing some pretty intense training, and that training would be fairly specific on even how to apply for this license that you now are required to have. Some of the providers are big, of course, and some are small. There's a whole range. But the first visit would be a technical assistance visit, and that's in the language already. So it isn't that people are going to be suddenly held to these standards, and then if they're not compliant that first time around, that they're kicked out. The idea here is that we would be working with people to provide this technical assistance to get them on board and comply in compliance.
Mr. Chair, one final question. How does this save costs in the system? If we impose this licensing structure and we have a certain thing in place right now and costs associated with that, and then we're going to presumably do this, how does that reduce the cost of the services that are provided?
Mr. Kerber.
Mr. Chair and Senator Hann, I'm not sure that it directly reduces cost. I think it deals with a threat of loss of the federal match for some of our services, but it's shifting some costs. Some counties are going to have a relief in their county contracting expectations and some of their oversight. And some of that's moving to the state, again, not for an enormous amount of money, but it is moving from the counties to the state. So it isn't necessarily a reduction, I don't think. And I don't think we've been portraying it that way.
Senator. Mr. Nelson, do you want to offer a comment?
Thank you, Mr. Chair. I'm Bruce Nelson with ARM. And we recognize the importance of moving forward with something along the lines of, this is related to 245D that's attached to the payment methodology in Senate File 1675, to help us get the extension we need in that regard. But if I may share our vision of how this can play out, and I think it answers some of your questions, Senator Hann. A couple years ago, we passed, ARM proposed, and the legislature passed quality outcome standards, also called a single set of standards. And in working with the department, that was to be come forward this year, along with the residential support services that came from the department and adopted a couple years ago. That is now into what is being called a Tier 2 to come forward next year. And in doing that, there would be some integration with the 245D. Our vision is, I think, very similar. We have 245B around licensed services, 245D now for picking up a lot of the unlicensed services. We acknowledge the need to do that. We also acknowledge, or we recognize the need to reduce the regulation and oversight that's now in 245B. So what we would like to work on and bring forward next year to the legislature is using 245D, if it's passed this year, as the base. And then take the elements we need out of 245B and incorporated them in along with the quality outcome standards, or the single set of standards, so we have a single set of standards, and we can find then the economies that you're looking for, Senator Hann, in having a single fee and not having redundant fees.
Senator. Any other questions? Ms. Bartalik, did you want to say something, or you just...
Mr. Chair, I'll just explain to the committee what she was doing. One of the things that I was mentioning is that we're going to be piggybacking on another existing group that's going to be meeting over the interim. And Ms. Bartalik was clarifying for me that our intent is really that we work with a group that, as Mr. Nelson talked about, the quality outcome standards. There are groups of people who are working on ongoing development of these standards for services, and it's probably that group that we've been meeting with, and not necessarily the fee folks.
And Mr. Chair, just to add that there are a lot of efforts that are going on right now to be able to try to manage these providers. And so I understand that the controversy about the fee is one piece of it, but to try to have a system that's more coherent and has specific roles for what the state does, as well as to assure that counties are providing value-added quality improvement and quality assurance is an important part of the entire package.
Very good. Any other questions? I want to thank you for this discussion. I want to thank the good witnesses that talked on all three topics today. I think these were three issues on the House side that were unresolved that I think are meritorious. So I want to remind people that the Human Service Conference Committee quitting at a little after 10 is often been a good start, and we're just getting warmed up by now, and so we're about to be done. Senator Hann will offer you some thoughts about his plan for the next meeting. But I want to thank everybody for their attention, and take another M&M for the road if you want. So.
Thank you, Mr. Chairman. And members, we are anticipating meeting again tomorrow, probably late afternoon, early evening. I'm not sure. Both the House and the Senate are in session. It's a little unpredictable when those sessions conclude. We also, as Representative Abeler had mentioned, there is some negotiation and some discussion about setting some targets or limits on what the bill that we have in front of us could spend. That has not been decided, and so I'm a little reluctant to get into discussion about adopting provisions into the bill that spend money until we're clear on what those limits are. So it's possible that we may not meet tomorrow if those things are still unclear and there's not determined that there's things that we can really productively work on. But at this point, I would just say that plan to meet tomorrow. We'll have to get the word out as to where and when, but it'll be after our sessions, whenever those may be, and we'll try to keep you updated if we have a change. But
is it likely in the Senate, or do you want us to have this one?
Well, Mr. Chairman, I think that we could meet in the Senate.
Oh, we can't have this room tomorrow.
We'll try and find a room, and we'll have to let members and the members of the public know, but we'd anticipate doing it over in the other side.
That's fine. Okay. Any questions about that? So watch your Twitter account. I wouldn't know how to do that, but somebody should watch it. Thanks for all the work. I think we did good today. Yes. Members and staff, put the little green sleeves into your folders. You won't be getting another one. So, thank you. We're adjourned.